All right, let's get septic. This is a favorite topic of mine. It's incredibly challenging. Well, let's not say challenging. Sepsis is one of those things that you'll either come to find is a protocol-driven, almost mindless thing by the end of your training, or you'll see it, like I see it, as an extremely heterogeneous medical problem that is fun to take care of, and every case is a little bit different, and you just simply don't know how each patient is going to respond to sometimes the same infection. So let's tackle it. Defining sepsis is such a mess. I mean, I in preparing this talk, I just kind of flash back and think, man, why is it that up to this point, the talks that I've had for sepsis were all not maybe what I wanted, and probably because if you're trying to do a talk based on source, and going by what's in the books, it's a little bit generic, and there's not even great consensus on how to define these things. So you have two different groups. You have right down here this Society for Critical Care Medicine, and you have this other group, not listed here, the Surviving Sepsis Campaign. And in general, they, I think, used to agree on this first definition here, and that's probably the one that most of you have heard at some point, where you think about SIRS criteria: temperature, heart rate, vital signs, white blood cell count. It's still something that I think it's fairly intuitive. And SIRS plus infection was sepsis, and then if you had some kind of organ dysfunction, elevated lactic acid, hypotension, you maybe had severe sepsis, and septic shock if you required vasopressors. And more recently, a couple of years ago, 2015, the Society for Critical Care Medicine came out with the Sepsis 3 definition, which uses a SOFA score, which is kind of like an Apache score. It's a multi-system 30-something calculated thing that it's essentially one of those kind of generic critical care scores, but it's essentially somebody who's getting sicker in the hospital. It's most of the things that make your SOFA score go up are the same things that make you develop SIRS criteria. And that plus hypotension or a lactic acid greater than 2 was, what they called septic shock. Essentially, the Surviving Sepsis Campaign is what drives what we do in our hospitals, and they did not adopt this definition. So you may talk about this definition when you're in the medical ICU, but in practice, the way the hospital protocols are built and the way that you're going to respond to sepsis using order sets and things in our hospital, it will be using this old system here. So that's kind of what I'll be referring to as we go forward. Signs and symptoms of septic, and the answer here is that just about anything could be, a sign for sepsis. Anybody who's got bacteremia will typically have nonspecific symptoms, and if you just ask somebody who's young and healthy who happen to have MRSA bacteremia or gram-negative raw bacteremia, for example, they'll tell you they just felt kind of fluish. And when I'm taking a history, though, for anybody who might be septic, the presence of fever is obvious, but chills and rigors are very, in my opinion, sensitive to help you kind of zone into someone who might have an acute septic presentation if you're doing an evaluation. It may sound generic, starting residency, but I could tell you, experience lays it forward that altered mental status, especially new onset altered mental status in the hospital, I think about it like new organ dysfunction, like acute kidney injury, and someone who becomes altered. To me, I'm thinking about sepsis as one of the most common reasons for someone to become altered, especially if they're already in the hospital. And being short of breath and having an elevated respiratory rate is something that even if you don't have pneumonia, that's going to be incredibly common in sepsis. Why is that? It's a high metabolic state, and you're going to generate more CO2, you're going to breathe more, and people who are in septic shock, may require so much, ATP and energy just to breathe with their diaphragm and such that it often is, a reason that they require intubation to help them get through that. And the most important thing here is focal symptoms, because I think focal symptoms, assuming your patient can give you a history, are the best way to zone in on, what your source is. But unfortunately, these other things here are kind of generic, and they don't really help you zone in on what you're dealing with. Vital signs in sepsis, and this is something that helps you in the ER or when you're already in the hospital and someone's getting sicker. These are the things that I think about here. So, having a fever, sure, that's, obvious. Fevers are going to make me think infection before I start getting into more creative causes of fever. But equally important, and what I wanted to emphasize here is low temperature. When I have a patient who the nurse calls me and their temperature is 93 or 94 degrees Fahrenheit, and it's a new change for them from what they were earlier in the day or yesterday, I take that seriously, and I take it in equal weight to if they had a fever. And I usually react to that too, for example. So if you have a patient who's on the floor, you probably want to do something to make that temperature come up, and you can't do that on the floor. So you probably send that patient to the step-down unit, IMC, and if you need to, put them on a bear hugger. And that's an intervention to do while you're figuring other things out. Tachycardia. Sinus tachycardia could be someone who already has chronic AFib or is prone to AFib, who comes in with AFib, RVR, rate greater than 110. New onset sinus tachycardia, though, to me is just maybe often the dark cloud over the baseball field. Something bad is kind of starting to brew up here. So think about it. Anytime you get hypovolemic, dehydrated, or developing shock of any sort, when you lose X amount of your blood volume, you start to develop tachycardia. And with sepsis, you're more so vasodilating, right? And that's what ultimately causes hypotension. But before you get hypotensive, your heart rate goes up, and that's going to help you compensate and, delay the period when you may become hypotensive. So that's why you might get tachycardic before you actually get hypotensive. That's why I put hypotension down here. Tachypnea, and again, so if you're developing elevated lactic acid, if you're developing sepsis, it's very common to just be breathing faster, taking deeper breaths. And if you are, for example, going to have a lactate that's greater than 2 or 3, you may see people just breathing heavy as a way of compensating for what is, developing an anion-gap acidosis. So tachypnea is very common, and with all these vital signs, the severity of the vital sign matters. Okay, and I'll touch on that later, but in general, if someone has sinus tach to 110 and a blood pressure of greater than 100, you have a little bit of time to work there. People can hang out with a heart rate of 110 to 120 and do pretty well while you're being a detective and figuring things out. If you have someone who's septic enough that their heart rate is greater than 130, greater than 140, when you get into the really high overdrive, the most severely septic patients, the people that are rapidly developing septic shock, their vital signs can get really animated. Their respiratory rate can be greater than 35, and with the heart rate too. So those things matter and how deranged they are. For your lab workup, anybody, and this is done by the ER if they come into the hospital with a supposed sepsis, and anyone who's on the realm of possibly being septic is going to be called septic when they walk through the door. So blood cultures before starting antibiotics is important, and no one's not going to get a lactic acid, and you'll be told over and over again how important lactic acids are. When you do order a lactic acid in the computer, there's an option for a point of care lactic acid or a whole blood lactic acid. And it's better to get the whole blood lactic acid. It actually goes to the lab. It's actually processed. A point of care lab, any point of care lab is done with like this finger stick glucose type of machine that gives you a rapid result. Point of care labs are really helpful in the ER when you have no idea what someone's coming in with. You can get basic chemistries, hemoglobin, things like that very quickly with a point of care set of labs. But those should usually be followed up with real samples sent to the lab. CBC with diff, and that's helpful not just to see what their white blood cell count is, but also for bandemia, which I'll get to in a minute. And other things that kind of just play into sepsis for me, and they're not specific at all. But to me, when I started residency, I probably thought more people would be hyperglycemic, but dropping your glucose is something that you'll see a lot with people that are septic, and it's something to keep an eye on. Remember that it's one of those things that can make people have a cardiac arrest and seizures and just general bad things. So if you identify that, fix it, and keep an eye on their glucose if it's dropping. Acidosis is obviously related to the lactic acid in this condition, which is why you often are getting a VBG when they come in, just trying to see what's going on there. Elevated creatinine from baseline. Sepsis is associated with acute kidney injury, even outside of just the general hemodynamic, reasons that are fairly obvious there. And you will find people who had a mild transaminitis and elevated bilirubin, and then a couple of days later it's better, their sepsis resolved, and then you might just go on to call that cholestatic or cholestasis of sepsis. And that's one of those things where all these things are abnormal when they come in, they're better 48 hours later, and some things you didn't know what was causing maybe the kidney injury or the transaminitis at first. When you look back 2 days later, you're probably thinking to yourself, okay, it was probably sepsis. There's one more thing here that I should have written down, which is coagulopathy. If you have someone who's barely acutely ill, someone who's not really going to the step-down unit or to the ICU, you don't need to necessarily worry about DIC and getting coags. But if you have a sicker patient, then I think it's reasonable to get a baseline INR. You could get a D-dimer, you can get fibrinogen, and for your ICU patients who are getting sicker, you could always see if those numbers are trending down, or if the fibrinogen's trending down, and if their INR is going up, and those things, then you might start thinking about if they're developing DIC as part of a worsening septic process. Red flags in sepsis as far as labs are concerned. These are things to remember. These are all things that I think stick with you and be important throughout your training. Anybody who comes in through the door or develops sepsis in the hospital and their first lactic acid is greater than 4, they came to party, they're sick, take them seriously, and don't try to write off their lactic acid as something else until you've really covered all your bases. If you look at their CBC with diff and they have more than 10% bands, this is probably the most sensitive marker for sepsis that I've encountered in my training. If you tell your ICU attendings that a patient has bandemia greater than 10%, they will often perk their ears up and listen to you. If they didn't take, maybe there's other things that everyone takes. Oh, maybe that matters, maybe it doesn't. Every attending I know takes bandemia seriously. And yeah, so people who are getting septic very quickly, who were declining rapidly, this is not something that I was prepared to think about before starting residency, but someone who's developing septic shock may go from awake and talking to you to obtunded and rattling airway secretions within 30 minutes. So it can happen quickly, and rapidly changing, declining mental status should always be a red flag to you and should generally make you escalate care and may require an ICU consult regardless of what's causing it. And like we mentioned a minute ago, severe vital sign derangements are a red flag regardless of if you know they're septic or not. Bandemia to me was kind of tough initially in training because I didn't always know where to see it in the CBC. So I wanted to put this here for you guys so you kind of have a reference for what it looks like in the labs. So I look at this on every CBC for anyone who I think might have infection, and that's it right there, okay? So if that number is greater than 10, it's greater than 10%, that's legitimate bandemia. Some people do, they look at the lymphocyte, neutrophil to lymphocyte ratio. I'm not really super familiar with that, so I don't really use that. And as you see here, this patient has a normal white blood cell count and bandemia. So I would still take that seriously. And if someone is getting sicker and it's 2 in the morning and they had a CBC, at 4 p.m., you can still get a new CBC. That's a reasonable time to do it if you think they're actually getting, septic as a new thing, because developing bandemia and spiking your white count, those things can happen very rapidly. I've seen someone have a normal white count and then have a white count of 40,000 8 hours later. Those things can happen very quickly. Lactic acid. You will talk about lactic acid so much, and I won't do too much with it here. But like the sentinel, the first lactic acid really matters. And if someone shows up with a lactic acid of 1 versus someone who shows up with a lactic acid of 7 or 10, those are people who stratify themselves very differently as far as what's going to happen from the data we have. So if you come in with a lactate greater than 4, even if your blood pressure is normal, 30% mortality within 2 days. If you happen to have hypotension and a lactate greater than 4, 46% mortality at 2 days. I mean, that's powerful numbers there. So that's why we look at lactic acids. When you have someone who starts off with an elevated lactic acid and you're trending, trying to get the lactic acid to go down below 2, you probably have little or minimal evidence to guide that practice. But I will say, if you have someone who comes in with a lactic acid of 3.5, they get their fluids and their antibiotics, of course, and now their lactic acid's 1.8, everyone feels better, everyone sleeps better, but there are patients where their lactic acids just kind of hang up elevated, and you can't always figure it out. But I honestly, despite all the learning you do in med school, I honestly, my general understanding of why lactic acid is elevated in sepsis wasn't very good for most of my intern year. And that's because I really probably assumed that you had to have, let's go back here. I assumed you probably have to be legitimately hypotensive and have like a systolic blood pressure or a MAP that's too low to perfuse the organs. But in general, that's not necessarily the case in the context of sepsis. And that's because sepsis is a dysregulated host response to infection. And beyond just vasodilating, you have a catecholamine surge, especially in someone who's not hypotensive yet. They're blasting out their norepinephrine and epinephrine to try and maintain normotensive blood pressures. And epinephrine can be metabolized down into lactic acid and make the lactic acid go up. So that makes sense. In general, for people that are developing sepsis at the cellular level, because of the cytokines being released and the underlying host response, that causes cellular dysfunction that in one way or another leads to, anaerobic metabolism and elevated lactic acid. At the microscopic capillary level, you may have shunting as a part of the vasodilation, and there may even be microthrombosis happening, which is causing, at a very small level, little baby cells to not get oxygen / blood supply and develop lactic acid as a anaerobic metabolism response. And yes, of course, if your blood pressure is 40 systolic and you are just frankly hypotensive and you're hypotensive for several minutes, that will cause global hypoxia and that will make your lactic acid go up very high. All right, and there's a source if you want to read more about why lactic acids are high in sepsis. And, before I get into this, let's go back 1 second here. The reason I do this is because it's very common for your lactic acid to be greater than 2 in a septic patient and to be elevated for maybe even hours before they actually become hypotensive. So it's helpful in that way, and that's why you should take it seriously. And just because someone's blood pressure looks good doesn't mean that they're not actually getting a lot sicker under your radar. So that's kind of why I'm putting these other mechanisms here, so you understand that you could have a blood pressure of 110 and still be developing, legitimate severe sepsis and be in shock in 2 hours. Now, there are going to be instances where you've had someone in the hospital for maybe 2 to 3 days and they look great. They're clearly not on a trajectory to be doing poorly. They may need to be in the hospital, but you're saying to yourself they definitely don't have sepsis. So sometimes lactic acid is elevated and we find another reason why. So if you had someone who is a heavy alcohol user or intoxicated on arrival, they can have elevated lactic acid levels as part of the biochemistry and how it relates to alcohol breakdown. I don't know, but that happens. And if they look great, they're hypertensive and they're on the floor, just you're treating them for alcohol withdrawal, and their lactic acid's 3, that's not necessarily, if they don't have any infection, sometimes that's just part of the alcohol. Lab error. This has happened a dozen times to me in residency, where you get a lactic acid level for a new patient that's like 8 or 10, and you're just like, wow, this patient's incredibly sick. But then you go look at them and they look good, they feel okay, and their vital signs are normal, In that circumstance, I question if we had a legitimate lab error, and that is common if, for example, in the ER, whoever drew that lab let it sit and those red cells started anaerobic metabolism, making lactate. That can give you a falsely elevated lactic acid. So my solution to this is just to repeat the lactic acid level and then see if, if you get a new lactic acid and it's 1.1, then you have a whole different thing. So this is, gets back to looking at the patient before you react and order 30 cc's per kilogram of fluids and a ton of antibiotics for someone who's coming in for a sore foot or something. So, just something to think about. But this is the exception. This is not common. Just have this in the back of your mind if you're ever just saying to yourself, this really doesn't make sense at all. This person looks amazing. And then when you think about this part here, and I know you guys will be around residents that are writing off elevated lactic acid levels because someone got albuterol or they're a cirrhotic patient. There are, without question, people who get albuterol and develop a type B lactic acidosis or other medications that do that, but it really doesn't. So when you try to write off a lactic acid that's elevated, especially in someone who's actually pretty acutely ill, you kind of only set yourself up to be right and gain nothing, or wrong and let your patient get a lot sicker and miss something big. So my answer here is, if you're trying to say this is a lactic acid elevation because of poor clearance or albuterol, that's fine if you want to make that call, but give your patient 24 hours, let them declare themselves, and be conservative while you're letting your patient kind of see how they're going to go. That's honestly my approach. Like I'm going to be a lot more conservative and treatment-wise aggressive the first 24 hours that I have a patient, and then if things are looking good, whether it's sepsis or other conditions, I'll start pulling things back if they're behaving in a way that shows that they're not actually going to be as sick as we initially thought. Evidence-based medicine, and I don't need to spend much time on this, but if you were to say, what's the real evidence in sepsis? What actually works in sepsis? Antibiotics work, and the time to giving antibiotics matters. And that's probably why the fraction of patients who come into the ER who get vancomycin and cefepime as part of their cocktail is extremely high, because doing it early makes a big difference. You will definitely see people who come into the ER and initially are hypotensive and very tachycardic. They look like they could have gone to the ICU. They get their antibiotics, they get their fluids, and the fluids are there long enough to augment the blood pressure, and the antibiotics are working within 1 to 2 hours, and the patient is now stable enough to come to you on the step-down unit or even the floor sometimes, usually the step-down unit. Fluids are a lot more controversial as far as how much these patients need, and the evidence is a lot more murky. That's also partly because this is such a heterogeneous condition. But in general, I think everyone can or should agree that if you're hypotensive and you're malperfusing organs and you're, that's just bad, and we need to not let that happen. So if I'm the intern and my patient has a blood pressure, less than 90, and they're septic, and I'm at bedside and I'm trying to figure out what to do, while you're figuring things out, give them a lactated ringer bolus and see if you can make that blood pressure go up while you're doing your detective work. And that's generally a good strategy. How much fluids, though? That's the good question. So in the ER, if they say, all right, this patient's septic, and if you declare somebody is being septic in the hospital, your order set is going to have you give 30 cc's per kg. And even with CHF, and renal disease, most patients will tolerate this much fluid. You're definitely going to see outlier cases where they don't, and they end up in the ICU or intubated, and that is what it is. So generally speaking, though, there's not an option here. You're going to get emails and such if you're not ordering that much fluid, and that's just kind of because that's something that's looked at nationally at hospitals. But after they've gotten that 30 cc's per kg bolus, if they're still hypotensive, that's when I think you really need to start thinking. And especially if they just arrived that day and they get up to the floor and they drop their blood pressure right after the fluids stop again, rather than ordering, 1, 2, or 3 more liters of fluid over the course of the next 3 hours, my general approach here would be to start saying to myself, all right, they're still hypotensive. I mean, that they're in shock. And even if their lactic acid is not going up, if they're persistently hypotensive, then that's when you should be talking about calling the medical ICU and bringing that up with your team. I think the one thing that you could do that is probably going to start to be harmful is if you're in this situation and you order 1 liter and then 2 hours later 1 more liter, and you keep saying to yourself, well, they're going to get better. There is a role for fluids if in these cases, let's say someone has profound diarrhea or they're vomiting and you think that they for a separate reason are hypovolemic as part of what's going on, then you could use that judgment and say, I think they're going to respond to more fluid, and I think that's why they're hypotensive. And if that's the case, then yeah, give some more fluid. But that's what I'm talking about, thinking critically. And if you don't have that, and if you have someone who has got a good source of sepsis, whether it's pneumonia or pyelonephritis or cholangitis or whatever, if they're just shocky, that's when you just need to realize that you're dealing with a condition that might need to be managed in the medical ICU. And talk to your team about making that call earlier rather than later. Procalcitonin. I'm less enthusiastic about this lab parameter than maybe other people are, but we'll go through it really quickly. We have a test for procalcitonin that comes back very quickly, and if you have someone who's developing septic shock, these procal levels are often super high, greater than 20, greater than 100 I've seen. And in those patients, I often could have told you that, yeah, they're septic. And the procal didn't really tell me anything that I didn't already know was happening. When you are evaluating someone in the hospital, for example, who's getting sicker, you think they might be developing sepsis, getting a procal with your lactic acid, might be a good measurement to help you sort of triage who might be more likely to have bacterial infection versus maybe a viral etiology. And in particular, somebody with upper respiratory symptoms, somebody who looks like it's a URI, for example. I think it is helpful here to help you confirm to yourself, all right, do I really need to treat sepsis when their procalcitonin is totally negative? That can help you kind of withdraw antibiotics earlier in a lot of cases. But there are limitations, and if you have a localized infection, if you have an intracellular atypical pneumonia, even Legionella, the procalcitonin may not be elevated. And if you have an ESRD patient or somebody with poor renal function in general, if they started off with an elevated procal, it's probably going to stay elevated. It's cleared renally, and that can affect how high the levels are. And let's say you're on nights, or one of your patients you've had for several days is getting sicker. One of the most, in fact, I would say I don't have to say it, the most common cause of inpatient mortality is sepsis. And that's why we have rigorous protocols in the hospital to catch and treat these patients as soon as they start to go downhill. So they use this thing called the Muse score, the NEWS score in the hospital, and it's based on vital signs. It essentially detects SIRS criteria. And if you have a patient who's developing elevated, vital signs and developing SIRS criteria, and that's when nurses are going to do this thing calling a sepsis alert, and you'll have to start this whole order set. And this is only the case if it's more than a day after, for example, if they came in yesterday with MRSA bacteremia and it's 12 hours later, then you don't necessarily have to do the whole order set again. But if it's been more than 24 hours, then the whole process restarts itself and you have to do all the fluids over again. It's part of the way the protocols work. And let's say it's somebody who did come in the same day. I might give another fluid bolus if I think they just need a little bit more time. Maybe they got 2 liters in the ER and they're a little hypotensive, but they're not really acting like they're going to keep getting sicker. I might give one more fluid bolus and get another lactic acid and see kind of where things are going. But for people in the hospital who are getting septic, I think that's where oftentimes you need to really hone in and see if you can identify what's going on. Sometimes there's an obvious source because they had a source beforehand. And in those cases, it's a little bit more straightforward. But if not, that's where you want to think about doing at least some rudimentary imaging, chest x-ray. You could do a urinalysis if they don't have a Foley. And you could always get another lactic acid and see, where things are going. And if somebody is already on antibiotics and they're clearly developing worsening sepsis, that's when I think you've got to ask yourself, why is this patient getting worse? And a lot of our slides to come are going to talk about source control and antibiotic coverage. And in general, rule of thumb, let's say you had somebody with pneumonia who's on ceftriaxone and azithro, and their oxygen requirements going up, their heart rate, blood pressure are changing. That's a situation where, when in doubt, broaden the antibiotics, throw them on vancomycin, cefepime, and see if they were just not on adequate antibiotic coverage for that infection. Should I call the ICU? Knowing kind of when you're dealing with an ICU situation is really key. And as an intern, you may not always be alone in making these decisions, but sometimes you are the person who is the first to notice something like this. And the earlier you relay this information to your attending and your senior, you can really make a difference in how fast patients get the care they need. So somebody with a lactic acid greater than 4, I would be looking for, I'm almost always going to call the ICU. If it's a patient who's actually septic with a lactic acid greater than 4, that's a whole separate stratification of people. Somebody who's septic and getting more confused, and I mean more confused like sleepy, obtunded, and hypoactive confusion. And that would be someone who's kind of working their way towards maybe needing the ICU. And the most common reason you'll have to call the ICU is someone who is just still septic after getting their fluids, and that's when you should think to yourself, if they got this much fluid, 30 cc's per kg, and they're still hypotensive, I think maybe that's someone who needs vasopressors. The Muse score is basically based on vital signs like we talked about. So somebody whose vital signs are severely deranged, if you have someone who, if all these things are really whacked out, the Muse score starts going over 6, the nurses are going to be, and they have to, they're required to call you and tell you, and they're going to keep alerting, calling rapid responses to that room. And that's because, generally speaking, if someone's got vital signs this deranged, they're probably too sick to be on the step-down floor on a general medicine team. Okay, so somebody with sepsis whose heart rate and sinus tach is like 135, blood pressures are in the low 80s, they're a little confused, and they're breathing 38 times a minute. That's somebody who, even if their lactic acid looks good, and even if you think that you're doing the right thing for them, you're probably just not going to be able to keep taking care of that patient at that level of care. Let's be a detective, all right? So this is the part that I think will be more fun, at least for me, going through this topic, and that's because we're not robots, we're detectives, we're doctors. You have a lot of money invested in your education. This is where you're going to use it, and that's figuring out what the source is and figuring out if you have source control. Come on now. What's the source? Let's just go through one by one what the most common sources are. And if you have somebody who has an infiltrate on a chest x-ray, or multifocal pneumonia read on their CT, or dense consolidation on their CT, that is pneumonia, and I love it. Pneumonia is a great source for sepsis. So if you end up saying, yeah, they might have pneumonia, I like it. That's a good source. And some patients require lots of oxygen, some don't. Some patients are ragingly septic with pneumonia, and some are just a little hypoxic and have a wet cough. The illness script for pneumonia is highly variable. Abdominal sepsis is a challenge, and it's a challenge because a lot of these patients are going to be surgical patients, and if the triage branch point in the ER went the wrong way, you could end up with a patient who is not really supposed to be yours, and then you're going to be caught with your pants down. But let's say someone had a CT abdomen in the ER and they have colitis on imaging. That's a fairly common reason to come in with sepsis. And these people, if they're having diarrhea, these are people who might actually need more fluids if they're still getting hypotensive recurrently, a little bit here and there after they get their 30 cc per kg bolus. We do have a nice GI PCR test in the hospital, If someone's having new onset diarrhea coming in from the community, and it can detect a lot of bacterial causes of diarrhea, parasitic causes of diarrhea, it's a good test. Viral causes, that is. And if somebody has prior antibiotic exposure, really high white count, and greater than 3 stools in a day, that's someone who, especially with colitis on imaging, you want to consider a C. diff test on. And the other causes of abdominal sepsis, like diverticulitis, your history is going to help you there, your exam is going to help you there, imaging is going to help you there. Intra-abdominal abscess is going to require an IR consult to drain that sucker. And a perforated bowel, that is no source control because you need surgery. Urinary sources of sepsis, overdiagnosed. And I do not believe, as we'll get to in a minute again, that simple UTIs are a good reason to be systemically sepsis. Having said that, opposite story is the case with pyelonephritis. I see a lot of gram-negative rod bacteremia from pyelonephritis, and having a kidney infection is a fantastic reason to be septic. So that's a legitimate cause of sepsis. Bone, joint, and soft tissue is an interesting and highly variable source of infection and sepsis. I think people with osteomyelitis, for example, I just don't think I've seen too many of those people truly be septic. They often need to be in the hospital, and they obviously need antibiotics, but they don't have such a vigorous systemic response a lot of the time. Whereas septic arthritis, especially if they have MRSA growing in that joint, may lead to MRSA bacteremia. Those patients can be in septic shock. And so it's variable. Now, soft tissue, aka cellulitis. Cellulitis to me is like a UTI in that it should not make you systemically septic. I'm not sure people with cellulitis should really be admitted to the hospital, but that's a whole separate conversation. But it is important to be able to think to yourself, is it just cellulitis? And know how to identify necrotizing fasciitis signs on your exam, which would be tenderness out of proportion to what you see on your exam. And somebody who's just really toxic with a skin source for sepsis, I would be thinking about neck fasc and considering imaging and a surgery consult to get them the care they need. Meningitis, not common, not subtle, not going to talk about it much here. If somebody has nuchal rigidity and they're septic, I think you'll figure that one out. Okay, so you're saying to yourself, they're coming in with sepsis because they have SIRS criteria and a lactic acid that's high, but I don't know what the source is. This is where you're going to be a detective, because sometimes people don't have obvious focal symptoms like we started the talk off with. You might just have malaise, dyspnea, and nonspecific symptoms. So people, let's say you have a Crohn's patient who's on TPN, they've got a port or a PICC line, bang, that's your source. Well, that may be your source. So hone in on that. If someone's had a PICC line for 3 months, red flag. If you have a dialysis patient and they have a fistula, take a look at that fistula and see if it looks inflamed, or see if it's tender, and see if there's maybe a wound there or something. And that would be a good source for, I mean, it's interfacing directly with the bloodstream. And, something that is often misinterpreted is in cirrhotic patients, if they have ascites. Some people think that people with spontaneous bacterial peritonitis or infection of ascites have to have abdominal pain or be, frankly presenting, but in fact they don't. And up to 1/3 of patients may be misdiagnosed by doctors just based on your clinical impression. So if somebody has ascites, stick a needle in there, get the fluid out, send it to the lab, and have a high suspicion for SBP in somebody who has ascites and cirrhosis. Sometimes if you still, after searching, haven't found a source, culture data, if it's coming into the lab within the first 12 to 24 hours, can help guide you as far as what the source or cause of your infection is. So for example, if I have someone who's got 4 out of 4 culture bottles growing MSSA or MRSA or some kind of weird strep, and that strep happens to be like dental flora, and it's high-grade bacteremia like that, and then you get another set of cultures the next day and they do it again, probably before that, but at that point in particular, you should be thinking to yourself, could this be an endovascular infection, aka endocarditis? And to start thinking about endocarditis, you should also be asking yourself, are these organisms that usually cause endocarditis? So, for example, Klebsiella, E. coli, gram-negative raw bacteremia in general, I would try to look for a different source, even if they're having high-grade bacteremia. They're not common causes of endocarditis. If someone's growing gram-positive cocci and it's greater than 1 bottle, so for example 2 out of 2 bottles or 4 out of 4 bottles or 3 out of 4 bottles, that's what I mean by high-grade bacteremia. This is somebody who might go on to have MRSA bacteremia, could still be what I put up here. But if someone, and we have this interesting PCR test that comes back early on positive blood cultures, so if you're on nights and somebody at 2 in the morning is growing 2 out of 2 bottles of gram-positive cocci in clusters, within 2 hours you may have a result saying that it's MRSA, okay? And if you didn't know the source and someone's growing MRSA, then that should concern you for a vascular infection, maybe in an IV drug user, right-sided endocarditis, septic emboli in the lungs, things like that. Look for an indwelling nidus again, because MRSA loves to infect things that are already sitting in your body. And then joint and soft tissue, but in general, if someone's got septic arthritis, it hurts, and you're gonna know. If you're surprised, and I've been surprised more than I would expect to have been surprised in the past year in particular, and someone starts growing 4 out of 4 bottles of gram-negative rods, and it's E. coli or some other gram-negative rod, then I would be thinking about abdominal and urinary sources for that infection. But in general, gram-negative rods come from a variety of sources, and I wouldn't narrow that down too much. One brief slide on urinary tract infections and sepsis, question mark, because during my time, I just feel like too often I see residents patting themselves on the shoulder and saying, this is a UTI, thumbs up, we've done our job, we're good. And so many patients, if you get a UA, are going to grow an organism, or they're going to have bacteria on the UA, or they're going to have greater than 10 white blood cells, and maybe they have a little bit of nonspecific urinary symptoms. I think UTI and cystitis are a medical problem. Sometimes they require antibiotics. I don't believe that UTI usually or ever should receive intravenous antibiotics. And if you're just telling me that it's a localized urinary tract infection, I do not believe that that patient should actually be systemically septic. And that's why, you see people diagnosing UTI as a cause for confusion or sepsis in elderly people, people who are disabled and can't provide history, people that have encephalopathy in general who just can't tell you what's going on. People kind of jump to the first piece of evidence they have. Very commonly, I see people trying to say that somebody's septic from a UTI when they have a consolidation in their lung, or some other better source for sepsis. So if you have anything other than a dirty urine to diagnose sepsis, then go with that. The caveat here, though, let's say you have somebody who's just got flank pain, or if you have a CT and they have stranding in their kidney, then yeah, that's pyelonephritis, and I love it. Pyelonephritis is definitely going to cause sepsis. And if somebody grows E. coli in the blood and the same bug grows in the urine, fine. You can call that urinary, cause of sepsis. And in those patients, I would still, let's say you have a man who develops E. coli bacteremia and it's from the urine, very often that's going to be from BPH and causing reflux of urine back into the ureters and into the kidney. In anybody who you're saying UTI and sepsis in, what you're really saying is that something is either causing urine to go the wrong direction, or they have, for whatever reason, developed ascending infection into the kidney. And that's how you should, in my opinion, think about that. And I think if you find yourself labeling less people as sepsis from UTI during your training, then you're probably being a better doctor and a better detective. This is an actual evidence-based slide. Thank you. Yeah, I do some evidence too. And it's sources of bacteremia by organism and by source for the sepsis in ICUs. Multiple centers, thousands of patients in Europe and the US. I included this here because it supports my last slide and my general feeling for what I've seen in my training, which is that gram-negative raw bacteremia is a little bit more common than gram-positive bacteremia, but they're pretty close. For those who are gram-positive bacteremia, Staph aureus and in particular MRSA is pretty common. For gram-negative raw bacteremia, Pseudomonas is most common, which surprises me because I don't see as much Pseudomonal bacteremia as I do. I see so much E. coli bacteremia. I'd love to see if this study from 2009 is different now. Maybe in ICU patients, Pseudomonas is more common, but I see so much E. coli bacteremia. And as far as sources for severe sepsis and septic shock, look at this. Pneumonia, 63%, which is why, again, I revert back to if you have an infiltrate, consolidation, that's your source. Bang, done. Abdominal, think about those things, cholangitis, colitis, all those things. There's so many different ways you can get septic from the abdomen, so that makes sense that it's the second most common source. Intravascular infection, endocarditis, port infections, just bacteremia from any indwelling nidus. I think that's what they're talking about here. Very common. And then urinary, bang, fourth most common, 14%. So again, if you find yourself labeling someone as urinary sepsis 80% of the time, then you're probably wrong. Skin's even less common. Source control. I talk about source control a lot when I'm on wards because I don't ever want to miss it, because if I miss it, I feel like I got caught with my pants down. You woke up in the middle of your nightmare, you're in the class giving a speech, and you're in your underwear. That's what it feels like to be the internal medicine resident who doesn't have source control, because all the fluids and the antibiotics aren't going to help you if you don't have source control. All right, let's talk about when you don't have source control. So if you have pyelonephritis or a urinary source of sepsis, this is why imaging is helpful. Because if you had a CT from the ER and they had a big abscess in their kidney, or if they had dilated ureters and hydronephrosis, or if they had a history of a stent, in the ureter, those are things that can be super infected. Urinary obstruction causing reflux acutely can provoke and continue sepsis and make them worse. So relieving these things and targeting these things can help you. If you have someone with an infected percutaneous nephrostomy, that tube needs to come out. All right, so an emphysematous pyelonephritis, not common at all, but imaging, if you had imaging and there's air in the kidney and they have pyelonephritis, I'd be talking to urology and seeing if there's something else you should be doing for those patients. Somebody with a stone in the ureter too, stones, super infected, it can be a cause of sepsis with, where they can provoke sepsis, and having this stone stuck in your ureter may be a reason that you don't have source control too. Most people with pneumonia you're going to have source control with, which is why it's nice, but be weary of the patient with a unilateral pleural effusion. Repeat imaging if they're getting worse, and if that pleural effusion has become complicated and they're saying it's loculated on imaging, that's when you need to be talking to your consultants about putting a chest tube in. For abdominal sources of sepsis, again, if you have an intra-abdominal abscess, you want to be talking to IR, see if they can put a tube in there for you. If someone perforated their gut, be on the phone with surgery. If someone has diverticulitis and they have an abscess developing or a contained perforation, again, surgery, surgery, surgery. And biliary sepsis, man, this is if someone gets cholangitis, first of all, don't ever say someone, you can say it, but people with cholangitis, they get so septic, and they get septic so fast. It is not subtle. So now, choledocholithiasis, having a stone in the biliary tree and hanging out with a little bit of pain, or just pain in general, but being stable, that's not cholangitis. Cholangitis is raging, caging sepsis. And if you have somebody who has cholangitis or even might have cholangitis, I'm calling GI because I'm getting the ERCP because I do not have source control, okay? Joint infections. Anytime someone has septic arthritis, that's going to be diagnosed after they've had a joint aspirate by orthopedics usually, and then ortho is usually going to take care of that for you, take them to the OR, wash them out. This is one of those rare things where you need a surgeon for an internal medicine patient all the time, but we usually have septic arthritis on our service unless they're going to do bigger operations for them. And for the skin, again, necrotizing fasciitis, be aware that it exists. really challenge yourself to believe that someone has simple cellulitis if they're really sick and there's a skin source. So sometimes a CT, the leg or wherever they're having a skin discomfort, if you think there's a skin source, a CT, if you think someone might have neck fascia, could show air, and air around where they have the skin infection might help you make that diagnosis. But again, one phone on the dial with surgery, because you're not going to be able to fix that with antibiotics. And again, intravascular infections, if you have someone who comes in with an infected PICC line, for example, when you take out that PICC line or central line that's infected, these people often defever vests and clinically improve rapidly. And you'll feel very strongly about how amazing having source control is once you've removed the source of sepsis for any of these things. But it's nice that for intravascular infections, this is the one thing where we can actually, you can call the nurse, pull the PICC line, or call the nurse and pull the central line, and then somebody who came in close to death at 6 in the morning at 6 p.m. looks like a different person, and that's a good feeling. Briefly, let's talk about choosing antibiotics by source. If you have diagnosed pneumonia, and it's for the majority of pneumonias, I'm going with ceftriaxone, azithromycin, community-acquired pneumonia coverage. For people that are going to the medical ICU, usually you're going to want to cover MRSA and just broad coverage in general. For other patients, if they had the flu last week and developed pneumonia symptoms after their flu was resolving, so post-viral pneumonia, that's a group that I generally think warrants MRSA coverage. Severe, like we talked about. Somebody who has just been in the hospital a lot in the past couple of years, maybe you should consider MRSA coverage on. Sometimes you can do a MRSA NARES test, and if that swab returns negative, then maybe you could consider just pulling away the vancomycin after that test comes back negative. And if it comes back positive, then you're just kind of left in the same situation you were before you ordered it. Meaning they're colonized and you don't know if it's an MRSA pneumonia or not. For gram-negative coverage, ceftriaxone, if you can get away with it, it's probably better for a pulmonary infection. But for somebody who has a lot of hospital exposure, if you feel like they are at risk for having resistant organisms, this is where your attendings are going to say pseudomonal coverage. But again, since I've only seen 1 or 2 people with a true pseudomonal pneumonia, I generally like the term extended gram-negative coverage, because you can have ESB E. coli and resistant Klebsiella, and all the gram-negative rods that can grow in the urine can get into the lung, especially for nursing home patients, elderly patients, people with kidney, liver disease, anybody who's older and their immune system's declining, or if they had chronic altered mental status, things like that. Notches off the old belt seem to just predispose people to getting these bugs down in their airway, and I don't have a great reason for that, but colonization or whatever have you. But they get down in there with microaspiration or frank aspiration, and then next thing you know, you have E. coli pneumonia or whatever have you. So just something to be wary of. So that's why if someone comes in from a nursing home and they have had pneumonias in the past or have been exposed to a lot of antibiotics, I'm going to cover them with cefepime, or Zosyn. I'm going to give them broad coverage. For urinary sources, again, usually gram-negative. So I feel like even in the ER, they could just say, okay, pyelonephritis, ceftriaxone, and we're done. But I try to pull away the vancomycin here if they're coming with a clear urinary or GI source. But if you look back at prior cultures, that's where it can help you. If you had someone on ceftriaxone, but you look back at their cultures and they've grown nasty, resistant E. coli or Pseudomonas, use that culture data and expand their antibiotics as appropriate. For anaerobic coverage, mainly for GI sources, anaerobic coverage is fairly controversial for a variety of sources, so I won't get into that here. And then choosing your antibiotics by source, let's see. So an abdominal source, I'm going to use gram-negative coverage and anaerobic coverage. So a common combination would be ceftriaxone and Flagyl. You could do ampicillin sulbactam here. You could do Zosyn here, which is piperacillin tazobactam. Either of those alone here. A Flagyl plus ceftriaxone gives you the coverage you need, though, and it's not overly broad. People used to do Cipro and Flagyl. We generally are trending towards using as little Cipro and Levaquin, fluoroquinolones as possible. In fact, if you order Cipro, you'll often get a message from pharmacy asking you if you really have to use Cipro. For skin soft tissue infections, I'm usually thinking gram-positive and covering MRSA until I find a reason not to. However, diabetic wounds should get both gram-positive and gram-negative broad coverage. Joints, always thinking MRSA here, and if you're lucky enough to have methicillin-sensitive staph, then narrow them down at that point in time. Somebody has infected port, PICC line, they're getting vanc and cefepime. They're getting broad coverage. Cirrhosis and ascites, so you think they might have SBP. Ceftriaxone alone should be adequate unless you had old culture data to show you that it wouldn't be. If you had someone say just start them on broad coverage, you might already know what that means, but just for fun, let's say you want to just review what that is. If you need MRSA coverage, vancomycin is usually all you need. If you're an EPIC, we have a vancomycin pharmacy consult, so I don't know if anybody watched their residents when they were a med student ordering vancomycin troughs and titrating vanc doses based on troughs. At our hospital, the pharmacy does that for you, which is nice. So when you put that vanc pharmacy consult order in, it notifies the pharmacy, they follow the vanc levels for you. And then, let's see here, if somebody's getting acute kidney injury and you think the vancomycin is at least not helping their kidneys do better, or if they're just getting sicker on vancomycin with gram-positive infection, sometimes that's when you should call ID and see if they need an alternative gram-positive agent to cover their infection. And if you need more advanced gram-negative coverage, cefepime is going to be good for you, or Zosyn. Anybody can order those, and they're not restricted. And remember, Zosyn has anaerobic coverage. I would generally trend towards saying you see more resistance with Zosyn. I saw somebody with cholangitis a couple months ago, and he grew a bug out of his biliary tree that was E. coli, and it was intermediate resistance to Zosyn. And that was an unfortunate finding for everybody in the world. And if you thought somebody needed meropenem or an alternative carbapenem, you're going to need an ID consult, but that's a whole separate issue. Last thing here, if you could avoid vancomycin and Zosyn together, which often you can, in fact I never order it together because very rarely, if ever, do you actually have to do that. It at least increased association with acute kidney injury, and I have a strong belief if you can avoid causing altered mental status or acute kidney injury in the hospital, you should try to avoid it. Narrowing down antibiotics is a complex discussion. It's a fortunate discussion to have whenever you're in a position to do it. But if you identify your source or you have cultures growing with a specific bug, often that's a reasonable time to make that call. If you're the night person, I don't think you often need to make big narrowing or broadening changes unless things are dynamically changing. But during the day, talk to your team, and if someone's growing E. coli in the blood, you can generally stop vancomycin, vice versa. It makes sense, right? For pneumonia, especially for people who aren't very sick, if your team wanted to keep a patient on vancomycin, at least initially, then day 1, day 2, after they're doing better, you might talk about getting rid of vancomycin, especially if you're just saying to yourself, like, this is just not someone who seems like they're going to have an MRSA pneumonia, because those patients are often very sick. And then if you have decided that your patient has pyelonephritis, generally speaking, I think you can get away with ceftriaxone in the majority of patients here, but look back at culture data, and that would be usually the only reason not to narrow them down to ceftriaxone. But if you have someone who has a history of ESBL infections, somebody who has demonstrated that they grow bugs that do not respond to ceftriaxone, that would not be a good option. I would keep them on broad coverage, gram-negative coverage, that is. And then lastly, somebody who came in with high Muse score and they look like they're septic and as far as their presentation, but then maybe they have lymphoma or some other thing going on. After 48 hours, if you really don't have a source and you don't think they're septic, that's a pretty reasonable time to ask your team, hey, can we stop these antibiotics? Briefly here, talking about causative organisms and testing, for pneumonia or somebody who you think has pneumonia, consider getting a sputum culture. And in general, if somebody has a dry cough, a sputum culture is not a good idea, not worth trying to get. But if they have a nice wet and they're coughing up nasty looking stuff in front of you, send it to the lab and see if it grows something. I've definitely seen sputum cultures change management. Unfortunately, there are a lot of skewed samples, so if it comes back with a lot of squamous cells, it's probably not going to be very reliable. Oftentimes, your sputum culture is growing some kind of gram-positive cocci or GNR, and you're like, all right, yeah, I'm going to have an organism, and then one day later it's normal respiratory flora, and then you don't have any useful information. But every once in a while you'll grow staph or strep or some other, or strep pneumo that is, and something that actually helps you kind of guide treatment. For people coming in with respiratory symptoms or infiltrates, you can always get an RVP, see if they have a virus, and you'll have a separate COVID test next year. People with diarrhea, like I briefly mentioned earlier, you have a GI PCR panel, which is very comprehensive. So if you're going to order a GI PCR panel, you don't need to order those old school tests like stool cultures and ova and parasites. This test encompasses all those things. It does not include C. diff. So if you want to test for C. diff, you've got to order a separate C. diff test. Obviously, urine cultures are going to be done on anybody who might have a urinary source. And then for people that might have osteomyelitis or might have septic arthritis, if you're getting cultures, that's not going to be at your hand. Someone's going to be helping you with that. One of the last things to touch on here is if you're the intern in the medical ICU, and especially if it's at night and there's not many people around, sometimes you'll be the only person there to answer questions. Nurses may come up to you and tell you, hey, this patient's hypotensive, they're septic, what do you want to do? And sometimes they'll just tell you, hey, I need an order for norepinephrine. And, usually in this context, it's probably reasonable. And in general, if you're the only person there, work with the nurses and try to help them take care of the patient. And anytime someone's sitting there with hypotension, something needs to be happening. So that's why, whether it's a small fluid bolus or giving the nurse an order for norepinephrine to briefly start in a peripheral IV, probably okay as an initial stopgap measure if you're in the situation. And, generally speaking, if you're in the ICU already, most patients, it's not unreasonable to at least start a pressor. If you're attending and fellow come back and you made the wrong call 30 minutes later, but the patient, nothing adverse happened, and with this plan here, usually not much adverse is going to happen over a short period of time. People are going to appreciate that you were, more active and hands-on. Let's see here. So, just to give you guys a reference, I had no idea about this stuff when I started, but if you're going to order norepinephrine, aka Levophed, and this is going to apply to a lot of drips and things like that in the hospital, when you order it, you're going to pick a starting dose and you click it in Epic, and it gives you an option of 0.01 or 0.05. This is a good time to ask the nurse, because oftentimes they'll tell you, hey, this patient's going to need more and more, so it would help me if you started it off at 0.05, and it would help the nurse also sometimes if they need to go out quickly to give them a higher titration dose. So if the patient's pressures are dropping, they can use a higher dose to move it up as opposed to the super small dose. And you might give them a titration frequency of 3 minutes instead of 5 minutes. Those are the two options that it gives you in Epic as a default. Max dose 1 mcg, which is the default in the computer too, but that's actually kind of arbitrary. Sometimes the nurses will actually ask you to give you the smaller doses and smaller intervals, or bigger interval, and that's because maybe if they're trying to wean down the norepinephrine, sometimes it's easier to wean it down by 0.01 as opposed to 0.05, if that makes sense. But you all will get more comfortable with these things as you start ordering it in the hospital. So lastly, key points: try to maintain stability. So augment their blood pressure with fluids if they're hypotensive. When you feel like, if you're at bedside, people are hypotensive in front of you and they're sick, order some fluids, tell the nurses to hang some fluids, take care of their MAP while you're figuring things out. Give Tylenol for fever, control fever. Don't use Toradol for fever in these patients. They're too sick for Toradol. They're probably already going to have an AKI. And give people a bear hugger if they're cold. If you can keep people's vital signs closer to being on the train track and not off the rails, you're generally going to be doing a good thing, I think, for the most part. And be wary of hypoglycemia. Just get a glucose. I mean, you're going to get a BMP, right? So look at the glucose, and if someone's dropping their blood sugars in the context of being septic, then make sure you trend the glucose and give some dextrose 5 or 10, either intermittent doses, or just make sure it's on your radar, and don't let people's blood sugar be the reason that they crash on you. And don't delay escalation of care. I think this is a communication thing, right? So if my intern has ordered 2 or 3 liters of fluid for somebody over the course of 3 hours, for someone who's been dropping their blood pressure, and I didn't hear about it as the senior, I'd be, kind of asking them, why didn't you tell me? We could have, probably gotten this patient transferred to the MICU back then, and that would have been better for them. Because at a certain point, giving extra fluid over and over again is not treating the underlying problem unless they're losing volume. And in that point, you're maybe just delaying the actual intervention, and you might actually be harming them. There's a little bit of evidence to show that excess fluid after that initial resuscitation may be harmful. And as I started the talk off with, and I'll finish it with, try to make sepsis fun. Everyone's different. This is a fun condition to treat. It feels protocoled, but after you get used to taking care of it, it can be fun. And let's see here. Antibiotics basically broaden the patient out when they're getting sicker. If there's any doubt, broaden them out. And I just did this again, so you're not a robot. So I hope this was helpful. I enjoyed going through it. You all will have another sepsis talk during orientation. You'll keep hearing more and more about sepsis.